interrupt me because I don't know what to do if it's quiet. So I'm an economist, if you couldn't have guessed already. So I'd first like to acknowledge funding from NICHD. And this is a project that I worked on a lot at the beginning of the aughts, and then it sort of sat after going through the first set of journals and getting rejected, and now I'm coming back to it, trying to finish off all the old papers that are sitting around. And I have a little bit of new results at the end that aren't in the paper. Okay, so let me start off with some motivation. As we all know, women in the developed world are waiting longer to have kids, and there have been a lot of changes. I'm going to stand up just because it's easier for me. And there have been big changes in the technology of infertility treatment over the last 30 years. Women in developed countries are increasingly likely to use it. And just to give you a number, in 1998, there were 250,000 cycles of IVF performed in the US and Europe. And in the US, about 4% of births and 30% of multiple births are after use of some kind of infertility treatment. And there's plenty of evidence that the infertility treatments affect use of treatments in fertility, but there's a big underlying question that parents and policymakers are interested in. Does infertility treatment itself affect health? Parents care about this because I think most people entering into the use of infertility treatment would approach thought, thinking about the whole process differently if they knew that it actually had a negative effect on health. And it's relevant for policymakers because they're the ones who are making decisions about what kinds of things are covered. Okay? So I'm going to skip this because I have a lot of slides. So just to give you some background on infertility, the clinical definition is being unable to conceive or carry a pregnancy to term after trying for 12 months without contraception, or 6 months if you're over 35. So obviously a definition like that's only relevant for women who are trying to get pregnant. But this is not the same as your innate ability to conceive or fecundity. Okay? So infertility itself is relatively common. The NSFG, which is the data that we have in the US about these kind of things, it's like the DHS for those of you who know that data. About 7.4% of couples were infertile at the time of the survey. And the prevalence of this 12-month delay for married women in developed countries ranges from 5 to 15%. So it's not uncommon, and it's much more common in groups like the women in this room. Some common causes of infertility in women: problems ovulating, blocked or scarred fallopian tubes, endometriosis. In men, there's abnormal sperm or not having enough sperm. And just to give you a snapshot idea of people who got in vitro fertilization, their diagnoses. So diagnoses that were tied to women, are mixed across a bunch of different categories. Diagnosis is tied to the men, about 20%, and then there's a lot that's unexplained. Okay? So just to give you some background on treatment, in the 1960s, we had ovulation-inducing drugs. My mom was actually in a clinical trial for Clomid. She used it for me and not for my brother, who was younger than me. And then in the early 1980s, IVF was developed, so we just recently had an anniversary of that. The first IVF baby in the US was born in 1981. And then there are a whole bunch of other things, including use of donated eggs and sperm, frozen eggs and sperm, injecting the sperm into the egg, and then intrauterine insemination. For assisted reproductive technologies, so things where the eggs and the sperm both are handled outside the body, Congress decided in 1995 that people needed more information, that people were being misled by clinics, and so they've required clinics to report success rates. So if you're thinking about a clinic, you can look up what their success rate is for live implantations, not donated eggs, and not frozen eggs, and find that. You wouldn't be surprised to hear that clinics have started to change the mix of things in response to the fact that this is being reported. But there's no requirement that they have to report anything about their non-ARM treatments. Okay? So as I said, use is common. Here are some statistics from the 2002 NSFG. So 9% of women 15 to 44 had ever had treatment to help them get pregnant. About half had used ovulation-inducing drugs. 13% had used artificial insemination, and not very many had used IVF. Okay? And about 3% had treatment in the last year. So that's 3% of all women. So that's not a small number at all. And now it's reported on the birth certificates of the 2003 Vision and Birth Certificate, which I'm not sure that all the states have adopted by now, but they report whether you used ART, not IVF specifically, but ART, and it's around 1% of births. So a lot of these treatments raise the probability of having a multiple birth, which on its face is just riskier in general. So ovulation-inducing drugs lead to about a 30% multiple birth rate compared to about a 2 to 3% natural multiple birth rate, and then implanting more than one embryo, obviously, if any of the extra embryos survive, also leads to a higher probability of a multiple birth. So in 1998, about a third of these IVF births are multiples. Okay? And then finally, it's expensive it's expensive everywhere, but it's expensive in the US and most of the costs are borne privately. So in a lot of, say, Scandinavia and Northern Europe, it might be paid for by the government, but there would be restrictions on who could get it. And there might be age restrictions. And the thing that they find in these places where it's paid for publicly is the rates of use are much, much higher than they are in the US for younger women. Okay? So there was an OTA study in 1992 suggesting a successful direct delivery would cost between $44,000 and $211,000. Various components of this are also expensive because you don't tend to just get one treatment. You sort of go through a process where you're getting a whole stream of treatments, and the lower levels of the ladder kind of lead to the higher levels of the ladder. And so this suggests that insurance coverage for this could be valuable.
Does the cost come down at all?
I don't know about the time. I mean, you would expect the cost to have come down some, but I myself have not used infertility treatment, but my understanding from friends who have is it's sort of much more like a business than most other medical treatments that you experience. So you kind of go in and they say, we're going to get you pregnant, you tell us what's up, and we'll pay us this amount. Some places even have a money-back guarantee if you can't get pregnant. Of course, they obviously probably screen who they allow to have access to the money-back guarantee. But so I don't know about the time series on that. You could look at it for recent years using claims data, I think, but that would miss a lot of the treatment. That's the tricky part about using insurance claims data for studying this, because lots of it's paid for in another way. Okay? In terms of coverage of treatment and health plans and mandates, well, if I'm going to try to get, so you guys might not push this, well, maybe I'll push this as hard as the normal audience of economists, but they really want you to show that there's a first stage, that that the law changed behavior at the firm level and it changed coverage for people. Okay? So I need that the treatment is somewhat expensive and not already covered. I don't have great data on that, but I'll tell you what I have. So there was a 1993 survey of health plans that reported amongst indemnity plans, think of that as being regular group health plans, about half covered testing of sperm and about a third covered Clomid, and about 1/7 to a little more covered IVF. Okay, so that's pretty different from a lot of other things that people. So there's a whole literature on other kinds of mandates, which I also work in, and that's very different from other things like other kinds of care that people study a lot are either mental health care or preventative care or childbirth. Those are the kinds of mandates that people have broadly studied a lot.
So in the prior slide, when you say the cost of delivery, is that the cost of the childbirth that is not covered because it's a complicated factor, or that's the cost of all the treatment leading up to?
Yeah.
But the delivery itself is covered under a standard plan.
Yes, the delivery itself would be covered under a standard plan.
Even if you're having
mandatory.
triplets because of
exactly.
That's still covered.
Yes. Okay, and so then, so this is a snapshot from before most of all the laws were passed, and we're close to when they were passed, and here's a snapshot from after. Mercer did a study and reported that numbers are somewhat higher, but still not at 100%. Okay, so numbers went up when the laws changed, but I can't show you the thing I would love to show you, which is the first stage evidence of that, because it's just, and that's also, you can't usually show that to these other kinds of things unless the laws changed recently. Okay. So I'm just going to very briefly touch on the literature, and I'm sure I'm missing a large demography and sociology literature, for which I apologize. Enough to say that, but not enough to have looked into it. Okay, so there's a big economics literature about fertility behavior, selection, and prices. Okay, so we know that you can't just, that there's positive selection in a lot of inputs. We know there's positive selection in which pregnancies are carried to term, and then the relevant other factor here is thinking about insurance. When you have insurance against, so in the context here, infertility treatment, the existence of it for women is insurance against the risk that they will not be able to conceive when they get older. Okay, and so there's a Hewlett book that a lot of people have probably read, where she goes and asks a bunch of women who are in their early 30s who are thinking about careers. What do they think the probability is of being able to have a pregnancy, and they're woefully uninformed. At that age. So the point here is that if you have insurance against risk, it might lead you to more risky behavior, and some people have put forth this idea that by having access to these kinds of treatments, women will wait too long, and they may regret it. Okay? There's a large literature on health insurance benefit mandates. So these are laws like this one that say that an insurer has to cover a specific treatment or particular kinds of providers. Okay? So the health insurance world, such as it is not covering these things. And this is also part of ACA. ACA requires all preventive care to be covered that's rated B or higher by the US Preventative Services Task Force, okay? So insurers aren't covering these things. Public entities get involved and say you have to cover this. And most of these are state laws, but there are some federal laws. An important thing to note here is that if it's a federal law, frequently it covers everybody, but if it's a state law, if you're self-insured, like everybody who works for the UC self-insures. So they aren't actually buying insurance, they're buying administrative services from Blue Cross, Anthem, and all these other insurers, okay? So ERISA says that those kinds of policies are exempt from this. But, you know, while you might think that a employer is trying to recruit older couples who might be high productivity, is going to maybe balk at covering mental health care or alcoholism treatment. IVF is probably the sort of thing you might want to cover. You know, it's not going to be that many of your people, and you know, it helps keep them locked in. And nobody used to want to switch their health insurance when they had a pre-existing condition. So you might get some effect from the self-insured firms as well. Okay. And so then the evidence about the effects of these things tends to vary a lot by the kind of mandate it is. So then there's a specific literature to this little area of infertility treatment mandates. So a paper of mine and Lucy Schmidt's in the NSFG, you can stack a bunch of NSFGs and you can look at whether states that had mandates reported getting more procedures. And we find that indeed they do. We can't really look at IVF because, you know, as those of you who know the NSFG know, it's not a very big data set, so if 1% of the pregnancies are using it, you know, it's just not going to show up there. But there's a big increase in the use of ovulation-inducing drugs and some increase in use of other things, okay? There's some clinic data where it's not, they can't really look at a pre-post kind of DD design. They're restricted to sort of cross-sectional variation because most of the clinic data didn't get collected until after most of the mandates have been passed, but they find that mandates lead to more cycles, fewer embryos per cycle, because if you have, you know, somebody else for paying for part of the cost, you don't have to take these risky measures at the beginning. And then finally, in the Fertility Data, other people have looked at this stuff. So I'm going to focus on the stuff that I look at that's about fertility that's different from these other papers. Okay. For treatments in infant health, basically, it's all observational, so, you know, I probably wouldn't believe most of it anyway, but, you know, it's all over the map. Okay? But the thing you should think of is what are people doing? They're, say, in some place like Australia, or they're in Norway, or they're in Sweden, and they have information on everybody who got something, who either went through a particular facility, or everybody in the whole country who ever got any treatment. And they do some sort of matching or age adjustment or something to make the people who got the treatment comparable to the other people. So you can imagine why we might not think that's totally causal evidence. Okay, so what am I going to do? I'm going to look at twins. Why? Because it's a population where there's a lot of use of ART and other infertility treatments. I'm going to argue that these state mandates provide plausibly exogenous variation in access. And I'm going to use a lot of population data because I need big samples. And then there's an important part here. In a lot of the other kinds of settings where people have looked at something that's changing the composition of who gets born, like abortion legalization, you think that the selection and the investment go the same way. Who has abortions? People who weren't going to invest a lot in their pregnancy if you force them to carry it to term. You can think about the evidence from Romania as evidence for that, from Pop Bellicus. Okay? Here, maternal investment is likely offsetting this negative health selection because who is getting fertility treatment? People who really want to have a kid. Now, maybe on the margin, the person who only does it when it's covered, maybe they want to have a kid a little less than the person who would have done it anyway. But it's likely to be offsetting from the selection, health selection. Okay.
But, Mary, but that's one form of selection, right?
Right.
This form of selection that is the selection across parents. Right? But then within a parent, you're going to have selection on survival.
Right, and that I can't say much about, although, you know, I do look at some of the infant mortality data. The issue, I mean, I thought about using the linked fetal death data, but, you know, arguments are that you can't get it consistently across places.
In an in-hospitable environment, though, you should be pulling out the kind of most robust. And
right.
So in some ways, that's...
So it's even, that's also positive, that's what you're trying to say. So then as you sort of improve the technology for keeping the infants alive, you're going to be pulling in less and less healthy infants as you go. Yeah. Okay. All right, so the data set that I'm using for the fertility stuff is just the natality, what I'm sure is familiar to everybody in the room, the US Mortality Data for 81 to 99. It's a near universe of all births. I have a sample of all twin births. I take a 2% random sample of singletons, because at the time I did this, now it wouldn't matter, but then the computer that I had access to, it was expensive to have all the singletons in the microdata. And then I'm also going to look at some twin delivery rates, where I look at the count of twin deliveries per 1,000 women with an estimate from the census. Okay. Then for the child health outcomes, I'm going to look a little bit at pooled data from the decennial census and the 2001 and 2002 ACS, pool them together. And so then you have a panel of kids who were born over a set of years. So I'm going to look at kids who were 5 to 17 at the time of these censuses, and I know their state of birth. So I can look at, I can impute being a multiple birth by looking at pairs of children who are the same age in relation to the household head, whose mother is still in the household. So I can get a sample of twins there if I want to. There's obviously some measurement error there because we don't know quarter of birth, so they could be just 9 or 11 months apart. And the least healthy older twins are probably dead from this sample. Or if there's something that happens in the family and the different twins split up, I wouldn't know that because this is only people who are still in the household. Okay, so finally some numbers. This is the share of multiples out of all births from the birth certificate data from 81 to 99. So you can see this enormous change. Each dot here is a state. And here's just the means by time period, as everybody knows. Age at births is going up in general, so it's going up for singletons, more for twins, and much more for these higher order multiples. Okay? In part, that's because being older raises the probability naturally of having multiple births, or having more than one egg release at a time. Okay. So the health outcomes I'm going to look at in the birth certificate data are birth weight and then some cutoffs. I'm mostly going to focus on birth weight. We think it's pretty well measured in the US. Gestation and some cutoffs for that. And then the 5-minute APGAR score, which is an alternative measure of infant health when they first come out. So there's 5 different things they rank them at it. And they add up to 10. Higher is better. The child health outcomes I have are not the world's greatest, but that's what I can get access to in a big sample where I can get a lot of twins. So in the POMS and ACS, they ask whether these children have any of the following long-lasting conditions: blindness, deafness, or a severe vision or hearing impairment. That's one question. A condition that substantially limits one or more basic physical activities. That's another question. And then, because of a long-lasting condition, do you have difficulty in learning, remembering, or concentrating, or dressing, bathing, or getting around in the house? So these are sort of more. This one's more like activities of daily living for kids. Okay, so what am I going to do? Well, first I'm going to try to show you that I can both duplicate the previous literature and show you some outcome that I'm the first one I think to look at that is affected by these mandates, and that's having mixed gender twins. Okay, because obviously most of these things are not causing an increase in same, in monozygotic twinning. I mean, they actually do cause a small increase in monozygotic twinning, but most of it should be dizygotic twinning. So you should see a bigger increase in the share of mixed-sex twins in you. Okay. Then I'm going to look at effects on child health, and then I'll show you these 2 user results that are sort of pretty new and not in the paper that look at infant mortality rates. Okay. So this is the specification here. Y is one of my outcomes for person I in state T and in state S and year T. I have some X's that I'm going to control for. I have some state controls. I have age dummies for the mother. I have a dummy for whether there's an infertility treatment mandate in your state and year. I interact that with some age measure, and I have state and year fixed effects. Okay, so that's the basic specification that I'm going to estimate here. And most of what I'm going to show you is OLS or else weighted linear regression with weights being the denominators. Okay?
Sorry, so guys, a question. So what do we think the mechanism here is? It twinning, and that's kind of it? So in other words,
I think it's probably more than that, but I can't really completely decouple that, right? So there's obviously, if all you did was cause people to be more likely to have twins, their outcomes would be worse. I mean, not in some sense of, people who want to have a kid that wouldn't have a kid otherwise. I mean, I'm not saying that their outcomes are worse, but you take a random person and you shock them into having a twin, it's worse because it's a more risky birth. But also there's this potential that, you're pulling some people into the possibility of having children who couldn't have had them otherwise, who for the underlying health condition that made it difficult for them to conceive also have a less healthy birth. So I can't separate those things with this design. but I suspect it's both.
I think it's like, yeah, and then third mechanism would be whatever kind of medication or, you know.
Yeah, there's all kinds
It's a little
of,
bit ambiguous.
which I don't think they know a lot. I don't even think the doctors would claim they know a ton about all of this. Because, you know, unlike other things, they're not doing a lot of, there are very few experiments they do in this setting, because who's paying for the treatment? The patient, and then it's unethical to do experiments. The one thing they have done, not in the US, but somewhere else, was they experimented with reduction, so going from 2 to 1, if it looked like the 2 were doing well, or 3 to 2, because they have a thing suggesting you shouldn't do more than 2 embryos at a time, but not everybody goes along with that. So it's a mix. Okay, so the other controls are all of these things you might standardly put into something like this. Importantly, state and year fixed effects, so I'm getting variation within state across time before and after you've adopted a mandate, and then I have month of birth fixed effects in there as well.
So do we think, it's probably not much of a sample, but is this state at time of birth or state at time of conception?
It's state at time of birth, but it's not
Probably people
that
aren't
big
moving
a
that much.
change. I mean, it's state of residence, not state of occurrence. There's also some, you know, there could be a little bit of mixing because it's the state where you work that matters for your health insurance. So if, for example, you live in Connecticut, you work in New York City, you might be covered in New York City, or you might be some weird person where your company is covered somewhere else. But I think that's peanuts compared to the rest of it. Okay. So I've included state-specific linear time trends. It doesn't matter. When it's relevant, I'm using population rates and the census data. I'm using dummies for the small number, for most things, of missing right-hand side variables. Importantly, when I cut things by some outcomes, it's not reported in every state. So not every state has the 5-minute APGAR score across the whole time period that I want, or not every state reports mom's education. So I drop a state, and if it's not available for one of the times, I drop it for the whole thing. Okay? And I'm going to cluster the standard errors at the state level. All right, so the key outcome of interest is, did I live in an infertility treatment mandate state? And that thing interacted with being 30 and older. It doesn't matter if I were to use 35 and older, but the point is most of the people using this stuff are older than 30, okay? So it's, the dummy is 1 if the mandate was in effect during the year of conception in the birth certificate, or the birth certificate matched the death certificate, or year 2000 minus age minus 1 in the PUMS, or year 2001 or 2002 for the ACSs. Okay? I'm also going to think about the type of mandate, because some of these mandate, you know, obviously, as you might guess, the states have different rules for what they consider should be covered, so whether IVF is included or not, whether the mandate is one to cover or offer, and then the interaction of the two. As I already said, older women have much higher utilization rates. So here are some characteristics of the state mandates. This is a condensed version of Table 2 in the paper. So this tells you in each year which states passed a mandate in that year. So you can see West Virginia was an early adopter. They don't have a very strong mandate. Then Maryland and Massachusetts kick in pretty early. And then later on, Illinois is another very strong mandate. And then in 2001, Louisiana and New Jersey. This tells you which numbers say IVF is okay or excluded. So you can see a lot of them do cover IVF. This tells you whether it's a cover or offer mandate. You won't really expect to see a ton from offer mandates, although, you know, that what offer means is that they tell the firm when they're buying insurance, they have to be offered one package that covers this thing, okay? Now, if you happen to be just buying from Blue Cross, anecdotally, I've heard people who know about the premium stuff say, you know, well, most of the, if they had to do it in one, it would be covered in all of them, because it would be a weird employer that would want to buy some set of things on a menu where some of them covered stuff and some of them didn't, but I don't have any evidence about that. So anyway, most of the effects should come through cover, and they do. And then whether they cover all insurers, all group insurers who are not self-insured, no HMOs or HMOs only. Okay, so these are different dimensions on which the laws vary. The other thing you can see here is there's a reasonable amount of time variation. You know, not everybody adopted in 1 year, so that helps me with this DD design. And, you know, you can't, maybe it doesn't jump out, but there's some reasonable variation across places. You know, it's not all just the Northeast or, you know, places where rich white women live, although it's obviously a lot of places where rich white women live. Okay. So now I need to try to convince you that there's exogenous variation in these mandates, and that it's not just you know, things are changing and a lot of IVF is happening, and that leads to, you know, the states adopting stuff, okay? So, not in this paper, but in this other paper with Lucy, we've looked at state year characteristics, predicting time to adoption, including stuff like multiple births. When we looked at stuff in the NSFG and also in the birth certificate data, there are no lead effects of the mandate, so being going to pass the mandate next year doesn't predict anything about birth outcomes or use of treatment in the previous year. And then I'm going to show you a figure that's just an event study figure, sort of showing you the trends. Well, I'm just going to show you fertility. So this is my event study graph. So this is the women who are 30 and older. This is the women who are 29 and younger in the states where they adopted a mandate. It's a balanced panel. So I recentered 0 to be the year in which, you know, for your conception there was a law in effect. And my eye looks at this and sees it's nice and flat here, and then there's a trend break here, and this is pretty constant. So this includes also state fixed effects. So these are coefficients on dummies for the younger group for each year since adoption, and the older group for each year since adoption. Okay? It actually doesn't have state fixed effects. I misspoke because they're not both centered at 0. Okay? So the point of this is to show you that it's not like you just had a big trend in twinning going on across the time period. It just happened that the adoption of the law was correlated with that. But it looked like things were relatively constant in terms of the twin rates before adoption. Okay?
And then it takes a little while to take off because it takes a while to conceive and learn about the
Yeah, and people have to learn about it, and, you know, et cetera, et cetera. Okay. So I'm going to skip this. I'm going to show you some of the fertility results here. So this is the 2% sample of twins and singletons in the birth certificate data. So this just says in a pooled sample of singletons and twins, the outcome is probability you were twin birth, okay? So I can control, the reason I do that instead of just rates is because I control for a lot of individual X's that I can't control for in the aggregate count data because I don't know all the same X's that I know in the mortality data. So what you see here is my key coefficient here is cover mandate times woman is older than 30 when she conceived, and we see, you know, a small positive, very highly statistically significant coefficient, and it's not small as a share of the pre-reform mean. Okay, so before these things were in effect at the time of conception, about 3% of births to women 30 and older were twins, and afterwards that's gone up by 0.007 over the 0.03. Okay. This is just probits, so if you were concerned about the functional form, because this is a rare outcome, you know, here's the same coefficient here. This is the average marginal effect with the standard errors from the delta method. Okay. This is the twin delivery rates per 1,000 women. So this is sort of telling you about, if we can think of this as being like the extensive margin of how many twins there are total. And again, you see a big positive coefficient that's statistically significant. So more twins amongst women over 30 after these things are in effect. Okay? And you can see this is a pretty big effect. So it's about 0.15 on a pre-reform mean of 0.4.
What's our interpretation of the cover mandate coefficient being negative, that it's decreasing among younger women? Maybe
yeah, I'm not sure,
yeah.
you know, yes, you could interpret, I don't think that I don't buy that younger women were paying enough attention, but one interpretation would be, that's why I'm not calling this a DDD, okay? Because there can clearly be spillover effects. So just like with preventive care, if something would be better for my story if that wasn't there, but the sum is still close to statistically significant, for at least some of the specifications. Okay, and then here's the mixed sex twin births. So this takes out of the same sample of twins plus singletons, this random subset, which share are mixed twin births, and here you see a big increase in the mixed twin birth rate. And I'm not going to show it, I don't think it's in the slides, but it's a much smaller increase for, you know, either compared to the baseline for boy twin births or boy twin births or girl twin births. Because in the mortality data, you don't know who the dizygotic versus monozygotic are, but you know these guys are monozygotic. Okay? Sorry, dizygotic. Okay. So hopefully I've gone some way towards convincing you there's some fertility effects of this, and there is, as I said, these other papers that also show this. Okay? So now I'm going to show you the results for infant health. So this looks at birth weight amongst the twin births. And so if you lived in a state with any mandate, and you were born to a woman who was 30 or older when she conceived, you're 16 grams lighter, okay? So obviously that's small, but not everybody was treated in some way, so it's much bigger if you try to do some back of the envelope calculation to kind of figure out an effective treatment on the treated. If I split out by offer and cover, I see a negative effect of between 12 and 20 grams. If I look at gestation, it looks like it's all on offer mandate, so that's a little puzzling. I'm not sure that I really would want to sell that. And then if I look at APGAR score, there's a substantial, again, not gigantic for everybody, but through some reasonable back-of-the-envelope calculation, it's more like 2% decline in APGAR score, and under some assumptions for this back-of-the-envelope calculation was about a 4% decline in birth rate. Okay. Here's APGAR score split out. Again, a negative effect for cover and offer. There's only a couple of these offer states, so the significance might also be coming from over rejection when you only have 1 or 2 treatment states, and I haven't done anything to try to figure out more about that. Okay, so I look at singletons. The interactions are negative, but there's not much going on. I do a lot of robustness. So I've tried interacting the mandate variables with the share of women covered by private health insurance, because you can get estimates of that at the state year level. I've tried to interact the mandate variables with the share of the population covered by the mandate, so split out this HMO, non-HMO, all. And I've tried to interact the mandate variables with the share of women who work or spouses work at firms of various sizes, but that's much. Things look very similar if I lag by 2 years instead of 1 year, so I'm lagging for 1 year to allow for conception. If I lag by 2 years, you saw this sort of event study tells the same story. It takes some time for things to kick in. Okay. I've also done a bunch of other samples, and it doesn't matter. Tried single year of age dummies. Time trends I already told you about. Neonatal and obstetric beds per 1,000 women, so controls for these other things about the women's healthcare system. And then I don't know why you would do this, but people have asked, so. Okay, so now results for child health. First of all, in the again, probably not necessary. Hopefully you're either convinced or not convinced by the mortality data, but you can replicate these results on the probability of having a twin. The point estimates aren't identical, but if you look at, so you take this panel of kids who were born in different years from the 2000 census, and if you code according to whether there was state of birth in the census, so you can tell where they were born, and you can figure whether they were exposed to a mandate at the time of conception approximately or not. You can replicate the sign and significance, and the magnitude is a little smaller, which isn't totally surprising because some of the kids are dying, some of the families are splitting up, and I can't link everybody exactly because in the census you don't know the relationship of everybody to everybody else. You know the relationship of everybody to the household head. So suppose it's like grandparents, it's probably not many of my twins, but suppose it's grandparents with a kid and that kid has 2 kids the same age. You don't know for sure that they're, have the same mom. They could be cousins in some way. Both have, like if there's two daughters there, okay? So then this is the health outcome table. So each column is from one regression. So this is the same sort of setup as the previous results I was showing you. So this is the cover offer specification. So I'd like you to focus on this coefficient and this coefficient. So you can see these things are extremely relatively rare, happily, with sensory impairment and physical impairment. And so what do you see? You see that for 3 of the 4 outcomes, being born in a state where there was an infertility mandate in effect when your mom was 30 and your mom was 30 or older when you were conceived, leads to an increase in the probability that you had a sensory impairment or physical impairment, but they're not significant. And then a statistically significant increase in the probability that you had a limitation on your physical activities. So why would any of these things make sense? Well, if you're born super prematurely, then frequently there are issues with your vision. So for example, they give you surfactants and other stuff, and sometimes, some of these things can have, in fact, there was just this news about trial where they're figuring out how much oxygen to give little babies. And so if they give you too little, you die, and if they give you too much, you can go blind. So, being born super early is associated with sensory impairments, physical impairments, probably some limitations on mental activities and in the observational data, things like, being held back in school, and then also limitations on physical activities.
Do we expect this to sort of randomly occur for one twin, or that the delivery might be complicated such that one twin will be most affected, or should this always be for both of the kids who are in the household?
I think it depends on how you think that the thing works. If you thought it was just this negative effect that things are worse for you because, say, you were lower birth weight, there's considerable variation amongst twins in birth weight, and you could imagine it could happen to one and not the other. If you thought it was just something bad about having been exposed to the drugs, say, then I think you could imagine it could happen to both of them. But then, there are also strange things that happen to twin pregnancies. They can compete for resources. Sometimes they'll induce delivery early because one of them's stealing resources from the other. So I think you can come up with a story that would go either way.
Do you see more concordance and problems after mandate?
I don't know. That's not something I've looked at. That's a good idea.
Can I ask one clarification question? Going back to the mechanisms, so you're restricting here the analysis just to looking at twins.
Right.
So the mechanism isn't that the treatment caused more twins. It's
Well,
conditioning on the twins, then
the
it has to do
twins
something beyond.
But if the twins are different, like if the composition of who gets the twins is different, that doesn't have to be driven by the treatment itself. It could still be something about who's brought into the possibility of having a kid who has this health condition that's negative.
Mhm.
So because composition is changing, it still could be both. And so I'll try to show you some very back of the envelope things to try to get some big cost measure out of all of this under different assumptions.
Right, so, the birth weight they showed us was quite small, right? And so do you think of that as being an average that's capturing some distribution in which you see some of this showing up in one table?
Yes, because I didn't show it here, but
Yeah.
when you look at these cuts, there's also big increases, not just in, like low birth weight is not such a big deal right now, but, being under 1,500 pounds is kind of a big deal.
Yeah.
And the sort of much lower cuts, the increases are pretty big there, so I think that could be consistent with this. To be clear, I'm not going to claim that these long-run health outcome results are sort of, there's other things going on. I'm less positive that this is the, I don't know how many kids might die, especially since I'm going to argue in a minute that I find some effects on infant mortality of all of this. So, and you can see the standard errors are, much larger. I mean, I can rule out 0, but they're much bigger as a share of whatever the outcome is. There's only 2 stars on one of these, so, okay. Here's the results from the probits, which are consistent. So here you'd even be more concerned about using a rare outcome, right? Because the mean for this is only 0.01. The marginal effects here are pretty similar to what comes out of the OLS. And it's all driven by the stuff on physical activities. There's certainly no evidence that these kids are better off. Okay, so let me just sort of summarize some of these findings. So I found more twinning, more mixed-sex twins, more deliveries, and somewhat lower birth weight, gestation, lower APGAR scores. Okay, so immediate effects suggest either the people who are being pulled into conception have worse outcomes because purely selection, or there's something going on about the treatment itself. Okay. Then these longer run effects, I can replicate this in my sample from the ACS and the PUMS that it's indeed this similar twinning increases and some negative effects of being born to an older mom in a mandate state. So then finally, the other good source of health data that's easy to get your hands on that goes back in a period that goes far enough back to span these mandates is infant mortality data. Okay, so for this, I went to the linked infant death. So the NCHS collects from most states, maybe all states, this linked infant mortality data in the first year linked to the birth certificates. Okay, and so they don't tell you which ones are the twins or triplets or whatever, but I probabilistically linked them, or I had in my RA probabilistically linked them. And so that's how I'm getting twins and triplets out of that data. So people had to share a whole bunch of common, that's the way I got the twins out of the vital, other than the mortality data too. You have a whole bunch of X's on the characteristics of the individuals, and if they match with a different, people, that's how you get the twins, okay? And so then I have it from 85 through 2001. The 83, 84 data doesn't have the same stuff in it, but it's kind of robust in including that. And so far, I've just run it for twins and higher order multiples. And so for some clauses that you think could be plausibly linked to having been born after use of infertility treatment, so neonatal deaths, deaths from causes in the perinatal period, congenital anomalies, and then causes that are linked to short gestation and low birth weight. These are the things where I would expect to find an effect. So this isn't a long-run health impact, but this is sort of a more important health impact maybe than these other things. And then I have a few placebo causes. Okay, so I have pneumonia, septicemia, accidents, and homicides, none of which should have anything much to do with infertility treatment, I would think, unless it's stressing you out so much that you then, that has to be a rare outcome. So effects overall, there's a significant increase in infant mortality in states with mandates for the older women, and it's about 9% of the pre-mandate baseline. But the main effect is positive and significant as well, so I'm not so sure to think about that. The effects for the older women are concentrated in no IVF states, offer states, and cover offer in no IVF states. So and these results are what make me not want to sell the other ones as being a DDD, because it's clear that some of the younger women are being treated as well, just not as much as the older women. Okay? All right. So now, since I'm an economist, I'm going to say something about some overall welfare, or at least costs here. So again, let me just be clear, this is not meant to be a cost-benefit thing in any way, shape, or form. Obviously, these children have tremendous benefits for their parents and possibly also for society. Okay? So just to be clear about that. So there are two things you can think about. Is there a change in how many twins were just born in the way that you sort of asked, Kristen? So the extra twins born to women who are 30 and older from this mandate, just a back-of-the-envelope calculation, take that number, put it on the baseline for a particular year, you get about 6,000 more twins from an any mandate, or if you impose a cover mandate everywhere, you would get about 13,000 more twins, okay? That translates into the cost. If you just take the average cost of a twin delivery relative to a single twin delivery, that difference of $146 million from the any, or $320 million from the cover mandate. Okay, and to just give you some context, that's about similar to the cost of use of these ovulation-inducing drugs. Okay, then you could think about well, there's some displaced singletons, so maybe there's some cost to that you should also think about. Whether the twins came from nowhere, births that weren't going to happen otherwise, or whether you made an assumption that they all came from singletons, okay? So if they just displace singletons, obviously these cost measures should be smaller because you should adjust it for the singletons. But then there's also an increase in the probability of twin dying from lower birth rate, okay? And this is just taken from the average in the population. So if you take the distribution of birth weight and mortality for twins from a particular year, from some work by Sharon Phibbs, and you just because of the difference in the birth weight alone, it's about 6% more likely to die from lower birth weight. Relative, this is percent, not percentage points, or about 4% from the cover mandate. So this takes the distribution of birth weight amongst the actual twins and mortality in that, compares it to the birth weight distribution in the singletons. Okay. The cost of the lower birth weight for the twins, there's also some stuff that breaks out the cost by birth weight categories, so I can back that out. So if I take the most, so this cost all added together, the total cost of the twins from a cover mandate is on the order of $330 million if you were to impose that everywhere. Okay, so that's not, that's not enormous, but it's not tiny either. It's a cost that's probably, being shared between public programs. So in the state of California, there used to be this program called the AIM program, and it would cover you if you had a terrible birth outcome before, when there used to be these out-of-pocket limits from private insurance. Suppose your infant was born super early, super premature, super sick, costs go above the point where your private insurance covers it. The state of California had a program that stepped in and paid for the rest. Okay, so they would cover after your insurance wouldn't cover anymore. So some of these costs are certainly being shared by the public sector, okay? As well as being potentially not all paid by the people who, you theoretically want to have pay them if you were trying to sell this as something to people who would benefit from it. Okay. All right, so some extensions or puzzles. It would be very interesting to know if it, I mean, I think it probably increases the number of children ever born, or at least at some point it did, but maybe now it's just affecting timing. Learning more about that would be fascinating. I'm not saying this is a fantastic design for that, because there aren't any good big data sets that would let you do that super well in the US. But there is the prospect for that in some of these Northern European countries, I think, where if they have changes in who they'll pay for it for. And then, you know, personally, I'm really interested in what determines coverage decisions of firms about this. Because again, I think this is very different from some of these other health insurance mandates where, you know, you're mandated to cover mental health stuff, but if somebody becomes not productive as an employee, you as a profit maximizing firm want to get rid of them as soon as possible, right? But, you know, these employees you might want to keep. Okay, so, and I'll wrap up here. So I hope I've convinced you that these infertility mandates affect fertility and infant health. Certainly, I think I can show that twin births are more common amongst older mothers who live in mandate states, that they have somewhat worse birth outcomes, potentially some negative impacts, somewhat higher mortality rates, and these results suggest a combination of this selection, possible moral hazard through delay, or negative impacts of the infertility treatment itself. And I agree it's really unsatisfying to not be able to parse those apart, but I think to the extent that you think that these are, you know, the investment is positive amongst these women in ways that I can't completely measure in the data that I have, at least you might think that this is a lower bound on the costs of these things.
All right, great. So we have a few minutes for questions. You can call them, I can call them. Welcome, myself.
Okay.
Great. So I wondered, in these mandates, are they specific with regard to how many embryos can be implanted?
Yeah,
Do they say you
there are a
have
lot
to
of-
have more than one, like, come on, we're not going to pay for this over and over again, or not?
No, it's more like they say, we'll pay for up to 4 IVFs, or, you know, we'll pay for them up to 46 or whatever. And I haven't really explored further the sort of more the specifics of these laws. That's another, you know, way to go, is to try to code these up. And, you know, because
You have offer and mandate.
yeah, but you also, so for example, Massachusetts, I think, is probably the most generous law by far. And Illinois is also very generous. You know, Connecticut was sort of a late adopter, but they only cover stuff to 40. They're not a mandate I'm taking advantage of. Other ones maybe only cover to 46. You know, I mean, so there's variation across these.
But is there some possibility, like conditional on doing IVF mandates reduce the probability of?
Yeah, I think that's what so I don't think my results are precise enough to say anything much about that, because I have no idea how many they implanted. But the sort of cross-sectional evidence suggests exactly that. So they looked at sort of before and after, and well, it's not really cross-sectional, sorry, before and after evidence in Massachusetts. They found fewer embryos afterwards because people, you know, had this relatively generous coverage.
So I had a few quick questions. So one was, in looking at low birth weight and infant mortality, there's this relationship that the better we get at saving very low birth weight babies, then the worse the birth outcomes will look. And so this seemed a little bit analogous to that the better we get at helping people conceive or have kids who otherwise couldn't, then we might take a hit a little bit on birth outcomes. But it still seems like a complicated policy bottom line. And I think you recognize that, but I wondered if you thought that analogy made sense. And
I think in part it has to, right?
Yeah.
And I mean, because, you know, so I think a clear policy implication of this is if you talk to doctors, and I mean, I got dragged in once to one of these big NIH things where they have everybody who works on infertility, they need somebody to say something is a bad idea, so they find some economist who will come and say it's a bad idea, right? So unexpected consequences, you know, lots of people want to get this stuff done and they don't believe that it's going to be bad outcomes. We know people are bad at estimating probabilities for low probability events, and they maybe think nothing bad is going to happen to them, and then they end up with some, you know, maybe they're still happy, but full information at the outset seems like the appropriate thing. And certainly, you know, I think the doctors at the time, there were a bunch of, this was before they put through the new guideline that they want to only put in 2, so it's not binding, but the our group, the people who do this stuff, say you should only put in 2. they wanted somebody to tie their hands, because they say they can't tell the patients, like, probability of a successful pregnancy is higher if you put in more embryos, but they know that it's bad to put in a whole bunch. So I think there's a clear policy implication that, maybe people don't want to hear it, but more information is better. That's separate from the, should we be paying for this?
Right. The other thing, I don't think that you can parse this, but in the beginning you showed a breakdown of the different types of infertility, and I wondered, thinking about the different mechanisms that came up, whether you'd expect different relationships depending on whether it was the mother or the father who was the person who led to the infertility. And so I'm thinking, like, if you think that the underlying mechanism, an important one, is the mother's health is somehow worse if she is infertile. That is quite different than a situation where the father can't, his sperm isn't, up to the task, and then she substitutes healthy sperm. So I wondered if there's any opportunity to sort of parse that, and then tease apart mechanisms. And then the last quick thing is just when you showed the different types of impairments, it seemed like the physical impairment was where you got a relationship, a significant relationship, and I just wondered whether when you look across the types of impairment, whether that makes sense to you, given a priori
So
assumptions
the
or mechanisms.
coefficients are, so, the results are mixed, so I'm trying to be careful not to oversell those ACS results, but, I would have actually, so the argument for physical stuff is, it's a higher prevalence event, and so, smaller, percent changes that are similar in something that happens 1% of the time versus 7% of the time, you're more likely to detect it in 7% of the time, right? But I would have expected to see something on, the vision stuff, actually, so I was somewhat surprised by that. And, depending on time, et cetera, I think that, if it turns out that there's some way in which so this can interact a little bit with ACA, what kind of is the gold plan, the bronze, silver plan covering. So there's some scope, or if another state passes a mandate, then there's these national surveys of children's health that are big samples that would be able to do a much better job of looking at this than, because it's a much better measures of health than what's in the ACS. So I would have expected to see it more in the vision, not to be completely honest. As far as the stuff from the mom or dad, again, that it'd be great to know about that. And actually, I think now, for more recent years, through the RDCs, you can get access to you can certainly get access to the clinic level data that gets reported, but I think you can get access to like the more micro level data that gets reported up to CDC through NCHS. But it's not going to help me because there's no policy variation from my design. So descriptively, it might let you sort of say, are the worse out, does things look much worse when it was the Because obviously there's also all this age stuff. Even telling if there's a negative effect in a causal way, whether there's a negative effect of dad's age on outcomes is challenging, right? It's obviously confounded with a lot of other stuff. So I'm, of course, hoping a couple more states decide they're going to start covering this stuff like very soon, and then it's a research design that I can push further.
Yeah, go for it.
So thinking about the parental selection issue in terms of the aggregate health of the population depends a little bit on the counterfactual, right? Whether or not you think it's, so the fertility results here would be interesting, right? Because these people have no kids, people who would be high investors have no kids, is it that they had a kid 3 years earlier, or is it that they had 1 kid? And then the selection on, or the impact on average parental investment in the child across the population is going to differ for each of those 3 things. Right, so I guess I think telling this story in terms of the net impact on population health will be useful to give the reader some sense of the counterfactual.
That's a very fair point.
All right, well, that was good timing. We should probably wrap up there, but thank you very much.